Dr. Sagal, Dr. Makovsky, I turn it over to you. Thank you so much for joining us today.
Thanks, Ben. Yeah, thanks for giving us the opportunity to talk about palliative care and ALS. I'm really excited to kind of share some of my growth and learning in this area over the past year. I've had the chance to work with Dr. Makovsky and learn a lot from her as well. So although I'll be the voice of the talk today, a lot of this comes from our experiences together and my learning from her. And Dr. Makovsky, welcome your input at any time as we go through the slides. So I hope that this is helpful and happy to answer questions at the end. We'll take a look at the chat. And so just to give you an outline, I'm going to give a brief overview of what we're referring to when we talk about palliative care, and especially primary palliative care and what that means. We'll talk a little bit about prognostication in ALS. We'll specifically address goals of care and how to discuss this with patients. Focus on symptom management to give you some tips and tricks for the clinic when you're seeing patients on your rotations. And then some resources if you're still interested in learning more after the lecture. And so what do we mean by palliative care? Everyone's familiar with palliative care at this point in your training. There is a breakdown of palliative care that we refer to as primary versus specialty that I think is helpful to think about. So primary palliative care refers to palliative care that anyone who is providing care for a patient can provide and is providing. So as neurologists, we're often taking care of patients who have progressive diseases that require aggressive symptom management. And that is in a nutshell palliative care and what we do. And we're doing this day in, day out for patients with ALS without regular involvement of specialty palliative care for the time being. There is specialty palliative care as well, and that's when a board certified palliative care clinician is providing that palliative care. And so there are situations where a referral to a specialist is appropriate, and we'll talk a little bit more about that. But when we say palliative care in ALS and kind of the focus of this talk, I just want to build the idea that we're all practicing primary palliative care for our patients every day with ALS. And so this is just part of a fundamental skill that I think is important for us to build as neurologists. And I just have a little picture here just to remind us that palliative care encompasses hospice care, but does not equate to hospice care. And so palliative care we're referring to, over the lifespan of an illness, whereas hospice care we're referring to more so at the end of life. And so again, just reiterating the point that I just made here, I will recognize that there are a few multidisciplinary clinics and growing numbers across the country that have a palliative care clinician embedded in their clinic, but most do not. And as a resident and fellow, it's important to both build these skills and know when to refer to a specialist. I'll just pause here before we move on just to focus in on a quote. This is hopefully to capture maybe some of what you might feel when you're seeing a patient walking into that clinic for the first time, and just recognizing that that is something that is probably a shared experience, whether you're a trainee or an active attending, providing care for a patient with ALS. And this is a medical student interviewing multiple ALS providers and their experience. This one here says, "The hardest part of this clinic is the implied anguish. It's implied that there's accelerated advancement of this disease, and there will be demise. It's implied. This disease is progressive, and you can never say, 'Come and see me in 6 months,' because you can anticipate that the struggle will continue and grow every day for our patients. But what we can do is offer support and be there every step of the way." And so I hope we can talk a little bit more about how we can practically provide that support and be there for our patients. So we're going to talk a little bit about prognostication. And so kind of before I dive in, there's a photo on the right that talks a little bit goes through the different types of ALS, and we'll focus in on a few types. But in general, for the median survival for ALS is between 2 to 5 years. And typically we're talking about death as a result of respiratory failure. There is a percentage of patients who survive longer than 10 years. There's patients who live 20 years or longer. And so that's important to understand. These outliers do exist from the median. And we don't currently have great prognostic predictors, things that we can use to help guide that prognosis a little better. It's really challenging in ALS to do so for our patients. There are some indicators that we can think about. So bulbar onset, if you're older when you're diagnosed, if you have concurrent FTD, frontotemporal dementia, if you had a fairly subacute onset and decline at diagnosis without a lot of delay, they tend to predict a poorer prognosis. If you're diagnosed when you're young, less than 40 in particular, we think about potentially having a better prognosis. And we think that genetic is fairly equal to sporadic for survival, although there's hope for new therapies for the genetic forms of ALS, and that might change. And then we think about bulbar onset, the median survival for this tends to be less, and only about 3% tend to survive longer than 10 years. And then in terms of the other forms of ALS that you see here, the survival can vary, and I'm just going to hone in on that a little bit here on this table. And I won't walk you through this table in complete detail. I think it's a good reference, when you're thinking about different types of ALS and prognosis. And so I'll just point out here for PLS, which is an upper motor neuron disease, the majority do progress to ALS, but if there's no lower motor neuron signs 4 years after onset, some people can live for a long time and have a very benign prognosis. And so it's important to recognize that there are these key differences. So some of the nuances in terms of the diagnosis and how patients are presenting is important to pay attention to, and will impact your discussions with your patients. When you're prognosticating, it's important to think about how you're talking to your patients about the prognosis and delivering that. When I've asked patients, or I've had conversations with patients about prognosis, these are just some of the things that they've said to me. Just give me your best guess so I can beat it, is what someone recently told me. I commonly hear this, very common. I know you don't have a crystal ball, but what do you think if you had to say? There are a good number of folks who want to hear your honest opinion, knowing that prognosis is difficult. They are looking for some level of guidance beyond I don't know. And then there's also the other way of going a little too narrow. A patient once said to me, the doctor gave me 6 months and it's now been a year, and it's hard to trust the doctors anymore. And so just to give you a little guidance, I would say overall, avoid giving any exact numbers. It's not the best practice to tell your patient, I think you have exactly 3 months to live, or you have 2 years to live. I think this this level of certainty is typically not as helpful as giving a range. And so in palliative care, it's very common in any situation for any disease for us to talk in these terms of hours to days, days to weeks, weeks to months, months to years. And for ALS, we tend, for the average patient, and obviously there are certain factors that are personal to each patient that might help guide their prognosis. But in general, we're saying a few years to several years. And it's helpful to say that some people surprise us and live much shorter, especially if there's complications along the way. And others surprise us by living much longer than expected. And that gives people some guidance, but also doesn't put them in a box. And it's also better than completely putting your hands up and saying, I don't know. So kind of use this as a reference for when you're delivering that prognostic discussion with your patient. Another common question that comes up in any neuromuscular disease or respiratory disease, is, will I suffocate, when they're thinking about the end of their life? It's a common fear, especially when we talk about being respiratory failure being the #1 cause of death. And this is entirely understandable. And so it's really helpful if we can provide reassurance that we're going to take care of them through the very end of their life, and that we have the tools to provide appropriate symptom management, prevent choking, prevent suffocating, at the end of life. And recognizing this, acknowledging this, not avoiding this conversation, what it does for patients is alleviates their anxiety and calms their fears. So this is not something that's keeping them awake at night, and maybe it still will be something that they struggle with, but if you're able to help guide them through this, it can often put some of those concerns to rest. I wanted to pause and just share, a patient voice, which I'll do a couple times in the talk. So this is, I'll play a clip it's about a minute long. This is the voice of Dr. Ajay Sampat. He's a neurologist who was diagnosed with ALS at the age of 36. He practices sleep medicine. Um, and he has a message that he wanted to share for directed towards residents and when they're caring for patients with ALS that I thought would be helpful just to hear. So I'm just going to play you a short clip. Okay.
Gordon, I've been giving these talks to residency groups, around the country now about my journey and experience, kind of like this. And one big theme I talk about with the residents and medical students is empathy, empathy versus sympathy, and why empathy is really critical to being a good, compassionate doctor. What I would say, my sort of general takeaway as a patient is really take a few seconds or a few minutes and just pause and try to put yourself in the person's shoes. And that's really what the heart of what empathy is. Try to put yourself in their shoes. If you were potentially given this diagnosis, if you potentially in a month could not work, if you potentially in 3 months couldn't dress yourself, if you potentially in 6 months couldn't drive your car, or in 12 months, couldn't actually stand up anymore, how would you feel? Take a few minutes just to think about that reality, and that's what the patient in front of you is going through. And I think if you can do that and pause and reflect, I think that empathy comes to the surface. And that's what I try to tell students and residents when I give this talk. And that's probably the #1, advice, or I guess pearl I would try to convey.
And reflecting on that,
And so I think kind of going along those lines of what Dr. Sampat was talking about, when we are talking about addressing goals and goals of care, we're often told, it's important to elicit values and goals, and you want to ask patients, what are their goals? What are their values? And I think having some language, some key phrases, places to get started is helpful. It was helpful for me as I was going through palliative care fellowship to think about, how do you elicit patients' goals and values? What kinds of questions are helpful to ask? And this is these are some tips here. So it can be as open as, tell me a little bit about yourself. What were things like before you were diagnosed? One of my favorite questions to ask patients is, what brings you joy? And this often leads to just a patient opening up and sharing their story. And sometimes it doesn't, but when it does, you get so much information about who they are as a person by like 4 words. And I think it's really valuable. So if you take away one thing, if you can remember that phrase, what brings you joy, it's one of my favorites at least. Some other particular questions, what are your sources of strength and support? Exploring their spiritual and religious beliefs, especially as people think about the afterlife when we're talking about a progressive disease. What is most important to you moving forward? And not avoiding when patient talks about their fear of death. I think that this is something that is uncomfortable and is probably naturally so. I don't think it's a natural part of what we're taught and how we talk with patients. We're typically talking about treatment plans, and so to talk upfront about death and fears about death is not it's not typical. It's not typically what we're trained to do, and so trying to lean into that is something that I've been also working on myself. there's a physician, Dr. Chachinov, a psychiatrist who studies dignity therapy, and Dr. Makowski. I mean, thanks for sharing, his journey as well. He asks a question of his patients, which is, what do I need to know about you as a person to give you the best care possible? And when I've asked this question or a similar question to patients, I also find that I get a lot of useful information that helps me guide them, especially when making difficult decisions about their care. And so when you're working with your patients, having this framework of hoping for the best and planning for the worst is a way to acknowledge that there's always room for hope, even in a disease that's progressive, without treatments to slow it down. But that our role is also to help them plan for the changes that are to come. And so balancing both the hope and the planning at the same time. And we'll use this phrasing directly and say this directly to the patient, that we're hoping for the best and planning for the worst. And this hasn't been shown to diminish hope when we're honest and upfront about how we are going to be supporting them through the journey. And when we're talking about planning for the worst, things we need to discuss include gastrostomy tube and what patients' preferences are about that, tracheostomy, and also identifying a surrogate decision maker who may or may not be their spouse, and it should not be the default assumption. And remember that when you're addressing goals of care and discussing these really important decisions along the trajectory of the ALS diagnosis, it's something that is probably not going to be done in one visit. There is going to be a deeper understanding that you gain of your patient's values as you get to know them over time. And as a resident, I think that's a little more difficult because you're mostly just popping in and out of clinic, and you might not have that continuity. But thinking about taking that over to when you're an attending, there isn't a day, a time that you need to get goals of care done. It's something that you want to try and build over time. And recognizing that your patient's preferences may also change over time as they learn more about the disease, adjust to life with the disease. And just to make one note about the disability paradox, which is that people who are viewing those who have a disability tend to think that they have a much lower quality of life than they themselves are experiencing. And so just being aware of this, that you may not know what someone's quality of life is unless you ask. And so it's helpful to not make that assumption. So we'll talk a little bit about tracheostomy. And I think this is a really important thing to learn about that I came across many times in residency, and I think was always challenging. I think it's a kind of a core palliative care skill in discussing a major decision in ALS care that I think is worth spending some time on thinking about before you first encounter this. And it might be when you admit someone to the hospital and you're having to make a tracheostomy decision and you're the resident going in to talk to the patient about that, or it might be that you're having an advanced care planning discussion in clinic with a patient along with your attending. Some helpful information to know is that about 10 to 15% of patients with ALS will choose to undergo a tracheostomy. And post-trach, the median survival post-trach is 8 months to 3 years, although we understand that this is highly variable. And we tend to think that the older you are, the shorter survival that you have post-trach. And of course, this depends on their pre-trach functional status and their comorbidities as well. These are some key points that I think we should talk about when we're doing shared decision making with our patients when it comes time to decide on make a decision about tracheostomy. Patients should know that this is a highly intensive treatment. This life-sustaining treatment requires 24/7 care at home. or in a long-term care facility if care cannot be sufficiently provided at home. So that when you're talking with your patient and understanding their values, understanding where what's acceptable and what's not acceptable to them. We have many patients who say, life in a nursing home on a ventilator would not be acceptable. And so when they're making a decision about tracheostomy, whether care at home is feasible might be a really key part of their decision making. You need trained caregivers. In the New York State, we'd need to have, at least here, two caregivers who are properly trained in the vent care before the patient can even be discharged home. And that's to make sure that if something goes wrong with the vent, there's always someone who knows how to troubleshoot and call for help. And they typically do need some hired caregivers as well for support. You also want to define endpoints before placement. So after the trach is placed, when would we discontinue this life-sustaining treatment? And that may be obvious to some patients, if I can't talk anymore, or if I lose all, my ability to, move, this would not be meaningful to me anymore. Or it'll be very patient dependent, but having that conversation is really important. We want to also discuss this early to avoid need for emergent decision making, especially with the risk of aspiration. Having this conversation early, introducing the concept and having it iteratively over many visits is very helpful. And sometimes it may only take one visit if the patient's voice is very clear, but making sure you do initiate the discussion early is important. And use what you learned about your patient. So, a few slides ago, we talked about the questions that help you understand their goals and values. Use that information to help navigate that discussion. And we try not to say, just blindly say, what would you want? Would you want a tube to keep you alive, or would you not? We want to try to help give them the information they need to help make an informed decision. About what life looks like after trach, what's acceptable to them based on who they were, as we're used to doing, in stroke care, very similarly. Okay, and so I wanted to share the voice of a patient who decided to pursue a tracheostomy. Her name is Chanel Hobbs. She says at the bottom, "Do I have any regrets about getting the trach? None at all." And there's a bit of text that I just want to guide us through here, because I think it's helpful just to hear the patient's voice directly. And she said, "Initially, I decided I didn't want the trach if it came to that. Honestly, I never heard anything positive about living with a trach or vent. I had heard either you would become bedridden, housebound in a nursing home, a burden to others, and miserable." And then Chanel had an urgent hospitalization for respiratory failure. And she says, "Even though I originally thought I would never be trached, at that moment, looking at my two daughters and husband, I decided that they needed me a little while longer, and I would do whatever was necessary to be here for them." And after she had the trach and went home, she wrote this post on the I Am ALS website and said, "Deciding on a trach is an individual choice that we all must make. One choice is no better than another. It's what's best for you and your family." And she reflects on the fact that she needs 24-hour care and suctioning throughout the day. She has an in-home nurse that comes in Monday through Friday from 8 to 5 while she works. And then her husband provides the remainder of the care along with family intermittently. And she mentions that she's able to work from home 40 hours a week. She's able to vacation and travel with her trach. And she remains socially active as well and is able to still be here for her family. So this was a very personal decision for Chanel that for someone different will look different. And that's exactly what she acknowledges here. This is not the best choice for everyone, but I wish I had a complete information on both sides of the trach decision. I know I didn't have a complete picture. And she recommends making sure you have it as a planned procedure, not emergently. And so being able to paint a picture of life before and after, I think is one of the key takeaways here, to make sure it either fits or doesn't fit with what a patient would want. And then another short audio that I'll play here is another perspective of life with a trach. And so this is a caregiver perspective from a longer podcast from Hidden Brain called The Ventilator. Now, this is a brief snippet, but just for some background, the podcast goes through the life of a nurse who has always felt really strongly that she wanted death with dignity. She never would want to be hooked on machines, and in her words, and it was really important to her to die naturally without life-sustaining treatment. And she ultimately was diagnosed with ALS, and during an emergent respiratory failure, had nodded yes that she did want a tracheostomy, and it was was a change from what her husband had understood about her preferences. And she ultimately had the tracheostomy and went home, and her husband and her son cared for her. And she was not able to meaningfully communicate while she was trached. And so it was really difficult for them to understand what her experience was. Um, and after her death, her son had uh, left a few comments on this podcast that I thought would be helpful for us to just listen to in terms of his experience.
This is Hidden Brain.
So let me just get this audio up here.
This is Hidden Brain.
She could at moment, and I don't want to go through that at moment. And I've thought about this so many times. She wasn't necessarily thinking rationally. She was thinking about, well, tomorrow, we can deal with the trach tomorrow. We're gonna deal with it tomorrow. I'll have tomorrow. I'll have the next day. Not right now.
Jason says that when he imagines himself confronting a terminal illness, he understands the dilemma his mother faced.
I know what I would say now. I would say, I don't want to go through that. I don't want to be trached. I don't want to be a burden on my family. I don't want to suffer anymore. I want to let me, end it now while my family still has these memories of me. And then I imagine being given that choice sitting across the room from my 4-year-old daughter and being asked, are you ready to leave this? Or across from my wife and being told that this is it. So are you ready to say goodbye to these two people that you love so much?
And so I think the voices here that we've heard, highlight how individual this decision is, how difficult it is, and how nuanced these discussions can and should be with our patients. So I hope this provides some additional perspective. And so, imagine you're in clinic and you're realizing your patient is telling you that they're essentially heading towards respiratory failure. They're having more dyspnea with exertion. They're unable to lie flat without getting short of breath, and they just started BiPAP. And you want to now, before it's an emergent situation, discuss the potential of a tracheostomy and whether that's within the patient's goals. And so a framework would be, asking permission. Is it okay if we talk about, your wishes around what would happen if your breathing changed? And assess what their understanding is about a tracheostomy. Had they heard of it before? Do they understand what life before and after a tracheostomy would look like? What would happen if they were not to pursue a tracheostomy? And provide that information. Explore the goals and values if you haven't already before having this conversation. And then explain some of the next steps. And that might include a discussion around hospice or providing the current plan of care with BiPAP until that point. Or it might include giving more information around tracheostomy. And there's plenty of resources for patients with ALS that are online that are we able to provide them with. And just to recognize again that preferences may change. You may have a conversation early on in someone's illness, and they may say, I would never want non-invasive ventilation by PAP. I would never want a feeding tube. I would never want a ventilator. And over time, they may adjust to that idea. And that might also go in the other direction. You know, I want to live as long as I can. Stephen Hawking's could do it, and so can I. And that may change over time, where they're feeling more frustrated with being dependent and worried about how they might continue to live with their current limitations for the rest of their life. And it may lead to a point where they feel like they're truly suffering and their values have shifted, and that's also okay. And I think recognizing that this can happen in both directions. We talk about G-tubes. You know, this is another point that we want to address when we're speaking with our patients with ALS in terms of their preferences. We don't have a lot of data about the benefits of a G-tube, i.e. no randomized clinical trials around survival. We think there's some weakly positive evidence that it may increase survival, but this is conflicting. And so we just want to talk about the risks and benefits with our patients. So, you know, it could stabilize their weight if they weren't really able to eat much. Now they have the artificial nutrition. They might not have to spend as much time thinking about so much about eating and drinking constantly throughout the day. And that could provide some relief for some patients who don't care as much about that. It could provide a form of getting medications in for patients who are not able to swallow. And in terms of harms, you know, there's the typical G-tube risks of needing tube changes and infection, and also just the care of the tube, if that's not something that the caregiver or family cannot manage at home, and that could mean moving into a facility for G-tube care and tube feeding administration. And so it's important to think about whether or not that would be acceptable to a patient, or whether being at home is really important. In terms of the timing, you know, we start thinking about it when we're seeing about 10% body weight loss. Just remember that ALS is a highly metabolically active disease. Weight loss happens as a result of multiple reasons, you know, poor appetite, the disease itself, and then an ability to swallow. In terms of the FVC, when it's greater than 50% of predicted, we use this as a number, knowing that there's a risk with anesthesia with a G-tube. And so talking about it when their FVC is still greater than 50%, to reduce that risk if it were to be placed. And so there is a way to get a G-tube placed via IR. This is also an alternate option. I won't spend too much time talking about that, but just to be aware of that as well. And again, just to highlight the reversibility of decisions. And like I mentioned, patients' preferences do change. And so, you know, a PEG tube can be placed and used for nutrition and then discontinued or not used. If a patient feels like it's not helping them meet their goals anymore, if they're not wanting to prolong their life, that can certainly change. Ventilation similarly can be withdrawn, and sometimes this can also be done at home with adequate support if that's important to them. So we'll shift gears to symptom management, but I guess before I do, Dr. Markovsky, I just wanted to give you a chance if there was anything else that you wanted to add. It's okay if not, but wanted to give you just a chance.
Sure. Yeah, why don't I just go over this? You did a great job. And what I thought I'd do is just highlight a few things. I took some notes while you were talking.
Sure.
One thing that you said early on, which I thought was so beautiful, those questions that you asked around prognosis, like, you know, with that variation in the wide breadth of prognosis and the difficulty giving a focused time. I think one of the key things is just avoid, as you had said, avoid numbers altogether. Use that range. But one thing that I do see is helpful for some people is to kind of think about what are some markers that we're at a different stage of illness. So often what I'll say is I'll ask, how much do you want to know? Because we can go through this today or we can go through it another time. If it is time to go through it, is to say some of the big markers that kind of suggest that time is getting closer, or our big decision-making places are weight loss, difficulty swallowing, increased difficulty breathing. And then even whether someone is getting respiratory support or nutrition support when someone starts sleeping more than 50% of daytime hours. So sometimes it's helpful for people to actually name what are some of those timeline shifts that make us in palliative care and likely neurology also kind of say, oh, this patient is at a different stage where they're getting closer and we need to think about the next phase. So that can sometimes help give people something to anchor with. The other question that I love that you asked are the questions around what gives you joy or what's most important. And I just want to frame why that is important. You know, at U of R, we talk, the medical students hear a lot about biopsychosocial medicine and the human narrative. So what I find really a wonderful puzzle in medicine is how do we help advise people about clinical options in the context of the person's story, their story as a human being, not as a patient. So the questions about joy, the questions about fear, the questions about what's most important, we start learning about what's their non-negotiables. What are things that they do not want to give up, that are the most important, that if we can hold on to those things about personhood and describe clinical care that can support those things or take away the fear, that's really important. And then with fear, you mentioned the question of fear of death. And you were there with me with a patient who said, I just want to quote Old Man River, that I'm tired of living and afraid of dying.
Yeah.
And then, do you remember what I asked him then about the afraid of dying?
Remind me.
I asked him, so people are afraid of the process of dying, and other people are afraid of the afterlife. Because the question of the afterlife,
Right.
that's when we start engaging our chaplain colleagues. The question of the process of dying, that's where we can start going in, okay, so tell me what you're afraid of. Well, I don't know what's going to happen. Do you want to hear what that's going to look like? And then you can start really answering those clinical questions, and how either if you have the confidence to answer those questions or want to refer to palliative care to kind of talk about what are those symptoms and how, and can they be palliated? Can they be addressed without an intervention? So that can be very helpful. And then let's see here, the ventilator, the piece that you talked about. What quote I remembered in that podcast that you shared was the husband said, I would have held on to, and I cherished every single day with my wife, even when she had ALS, even with maximal support until she had the trach. But I would have given up any of those days after the trach.
Yeah.
So one of the things that I hear, and this is one of the pieces that for me is one of the most tender things as a physician when talking to people about their shortened life expectancy. And for example, the son who said, if I had to think about my 4-year-old or my wife and the time lost with them, is this idea that they're never going to be ready. And their spouse or their children will likely never be ready for their death. Even 90-year-old patients, I have family members and patients who are not ready for that day. So this aspect of, I don't think I'm ever going to be ready to say goodbye emotionally, and yet I'm tired of living. So it's this aspect of, right, this is going to be so hard, and likely you'll never be ready to say goodbye. But it's how do we help you through that, and how do we help you prepare for that time, and how do you make the decision, recognizing that it's always likely to be too soon, and hold that space and let that be felt. I think is really just a tender piece, and it opens up and I think then the other thing is we know how to answer the questions about what can be done to prolong life, but to give a chance to hear, if I don't choose the ventilator, what will that look like? What will my life look like? What will my care look like? What will my quality of life be? So remember to answer both questions, not just what will look like on a vent, but what will life look like without a vent. So that's the, and again, if you're not sure the answer to that, that's a great time to think about engaging your palliative care specialty colleagues in that discussion. And then the G-tube, just one other option that's out there, is we often think of the G-tube with a tube that sticks out. A lot of our patients actually end up getting Minnie or Mickey buttons, which are little tiny mini buttons that close up, and you just attach the tube to it when it's time to eat and detach it when they're not, so people can actually take baths or do things, and it's much easier care. In Albany, actually, the GI clinic there that's associated with the ALS Center will put in the Minnie or Mickey right away without doing the G-tube first. And it really enhances some quality of life. So there are, asking your ALS team, when do you refer for the Minnie or Mickey in addition to the feeding tube, and how does that play into goals of care discussion, is just something to bring up. So those were my little notes that I wanted to add. Hopefully that helps.
Excellent. No, it was excellent. Thank you. So well put. Yeah, thanks so much for sharing that experience that you've had in caring for patients. And I think that's so helpful for the neurology residents. So thanks for sharing. With the I think we have like 15 minutes. We'll go through some symptom management, and we'll save some time for questions at the end, and go from there. So I'm going to go through, just briefly, we'll go through dyspnea and non-invasive ventilation. We'll talk about sources of pain and treatment options, talk about non-motor symptoms, and briefly psychosocial needs. And this is just a way to think about, when you're going into ALS clinic, you're rotating through, you're seeing a patient, what are the things that might be modifiable? What can I look for that I can help with in terms of improving their quality of life? And so dyspnea is a major area in which we can provide some additional relief. And so they might tell you that they are starting to have morning headaches, that it's starting with activity, or that they're having orthopnea. And so fatigue and trouble sleeping. Obviously, we're getting our pulmonary colleagues involved as well to help assess what their pulmonary function looks like. And in terms of treatments, you can see on the right here, this is a patient with ALS who is wearing their non-invasive ventilation. And we'll talk a little bit more about that separately. There is a cough assist device that can also help. And then there's low dose opioids that can also be helpful for dyspnea. To talk a little bit more about non-invasive ventilation, just on the right, there's just a few different masks. Sometimes patients will wear one during the day and a different at night for comfort. It has been shown to prolong survival and improve quality of life. Some of the numbers I was seeing for prolonging survival were on the order of many months to several years, but on the shorter end of years. So I think this is definitely variable depending on your patient as well. But in terms of improving quality of life, if a patient is able to tolerate the mask itself, you can imagine, just as a patient with COPD or OSA has trouble tolerating their masks, in terms of BiPAP or nighttime CPAP. So typically we're talking about starting this at night and then intermittently during the day as their respiratory failure progresses, for when they're becoming symptomatically hypoventilatory during the day. In terms of tolerance, you can prescribe very low dose of opioids or low dose benzos for tolerance, anxiolytics for tolerance of the mask, and low dose opioids for concurrent relief of the dyspnea. You can try an alternate mask type or patient specific settings for their comfort and tolerance of mask. We recently met a patient, Dr. Markovsky and I, that said, I'm just too claustrophobic. That sounds absolutely terrible to me to have to wear this mask. And so, there are some patients who just despite the possible benefits, the risks are not worth it. So it's important to recognize that despite all of the measures that we might have to alleviate that. It can be portable as well. And the key point here is that oxygen should never be used as a replacement for non-invasive ventilation. Now, we all know this too from myasthenia gravis and other forms of neuromuscular weakness. That we're talking about a hypoventilatory issue that's causing hypercapnia and not hypoxia. So, this is very, very different from when we're talking about primary respiratory diseases rather than a muscular weakness that's leading to hypoventilation and hypercapnia. So just remember that when you're thinking about the mechanism of dyspnea and ALS. And then in terms of pain, I'm not going to go through this diagrams. It's more of just a reference for you guys if you'd ever want to look back and refer to it, but I'll go through each of these areas of sources of pain in a little more detail. So if you're seeing a patient in clinic who has spasticity, it's not too different than how we treat spasticity for our other patients with neurologic disease, baclofen, tizanidine, Botox, sometimes benzodiazepines, although we have to be a little bit more wary of this in a patient with ALS in terms of our dosing. Sometimes we use high doses of Valium for patients with other forms of spasticity, but when you have neuromuscular weakness, you need to be cautious about sedating medications. Botox, a word on that is that sometimes that spasticity is actually helpful for mobility. And so you want to make sure you're referring to someone who's familiar with ALS and can assess whether or not that is going to be beneficial for their mobility or actually harmful. Our standard things being engaged with PT and OT, stretching the muscles, avoiding contractures is very important. Okay. Muscle cramps are very common. We don't exactly understand why, but again, just like our other patients who have spasticity and develop cramps as well, magnesium supplementation, mexilotine is also a drug that can help with cramps, baclofen, carbamazepine, and gabapentin. Massage and stretching if there's someone who's able to help with that in the home. In terms of unspecified pain, this is also fairly common, and we think it could be from underlying joint and muscle pain related to immobility. The non-pharmacologic things that we can do, customized wheelchairs, special mattresses, frequent repositioning, and PT, very important. And when you are part of a multidisciplinary ALS clinic are things that your team is going to be assessing for readily. And in terms of pharmacologic, we're talking about Tylenol and ibuprofen as first line. Low-dose opioids can be helpful. And so that would be a time to consider referral to palliative care if you have uncontrolled pain and your clinic is not one that is familiar with prescribing opioids. That would be a great time to refer to palliative care. And medical cannabis is becoming more widely discussed in the palliative care world, and we're using this for pain as well. And so it just depends on your state laws. In terms of fatigue and sleepiness, and I'm just going to peek at the time here. We do prescribe in palliative care clinic commonly modafinil and methylphenidate for fatigue and sleepiness of various etiologies, but obviously you want to do your underlying assessment or assessment for underlying issues. So is this depression related? Do they have a sleep related breathing disorder? Are they waking up because or are they fatigued because they're dyspneic? And other things that could be contributing. And so prescribing these medications can be helpful if you can tackle the underlying issue. That's preferred. A note on sialorrhea and posterior secretions. And so we'll make a point here to differentiate anterior from posterior secretions. So sialorrhea, we're talking about oropharyngeal drooling, that can be very socially isolating and bothersome for patients. These are the medications listed here that I would refer to. One of the things in residency that I would often see is that we would try atropine, we would try glycopyrrolate, and they can potentially cause anticholinergic side effects, or if they're ineffective, we would sometimes try amitriptyline as a TCA and also refer to Botox clinic for salivary gland Botox, as well as provide a suction device. Now, we have to be careful because posterior secretions are the secretions that are deeper within our chest, and so we don't want to use anticholinergics to thin those out, because a patient with ALS has neuromuscular weakness and is not going to be able to sufficiently cough up thick secretions. And so we want to try to do things to thin those out. So saline, nebulizers, humidified air, guaifenesin, a cough assist device, and avoiding the things that we've talked about above. And so just being aware that when we're talking about secretions with the patient and what the patient and family are referring to, that you're being very clear about where this is occurring, because that deeply impacts your treatment for them. In terms of insomnia, I'm gonna think fast forward here just with the time remaining. Our typical treatments here. Constipation as well, it's our typical treatments here. And same with depression and anxiety, although I'll just make a note here that I found that chaplaincy support has been incredibly helpful for our patients with ALS. So if your institution does have chaplaincy support, I would strongly consider engaging them. And if they don't, sometimes a palliative care clinic will have a chaplain as part of their clinic, and that could be a reason to prompt referral for spiritual support. A note on cognitive impairment briefly. About up to half of patients with ALS have some degree of cognitive or behavioral impairment, and up to a third may have FTD. And so this is very important to recognize. And I'll say here that this is one reason we really need to be initiating advanced care planning sooner. And as the capacity of the patient may change over time, it's important to make sure that their voice is heard and that their surrogate decision maker understands their voice and their wishes before their cognition changes. And so being aware that it's not a binary of having FTD with ALS or not, that there is some degree of cognitive impairment in almost half of patients with ALS. So just being aware of that. And a brief note on hospice and ALS. There are some criteria here that I won't go through, but I think because as neurology residents, we don't get a lot of exposure to hospice. I just wanted to make you aware that hospice can be delivered in multiple locations. It's not a place, it's an insurance benefit, a philosophy of care, and a resource that can be provided at home. It could be in a freestanding hospice facility, a hospice house that may be charitable from a charitable organization, or in a nursing home if there's no family support at home to be able to provide that, or a facility that's not able to accept or lack of available charitable hospice houses. And important to know, it does not provide 24-hour care at the bedside. There's a 24-hour on-call nurse and medication support and caregiver support with social work and chaplaincy often. But the care, if it's provided at home, does require family or hired support. And so other things to remember, if their patients are on life-prolonging medications or ALS medications at least aimed at prolonging life, those would need to stop because of typically need to be stopped due to insurance, lack of coverage by hospice as an insurance. A feeding tube does not necessarily preclude hospice. And happy to talk more about that if there's questions about that. It can be a nuanced discussion, but just because a patient has a feeding tube does not mean that they cannot enroll in hospice. So just in the interest of time, I'm just gonna wrap up here. So some key points that I wanted to make sure you all take away from today is that Initiate an open discussion to get to know your patient and explore their values, get to know them, their story, like Dr. Makovsky said, before you discuss advanced care planning with them. Maintain hope with the patient for the best outcome while supporting them in planning for the worst. Use the tools that we talked here to screen for motor and non-motor symptoms and see where you can make an impact on improving their quality of life. And consider palliative care referral for assistance with any of the things we talked about today. And I think having a low threshold to do that if there's something that you think would be helpful. And so some resources that you can take a look at, the International Neuropalliative Care Society. It has a conference in Grand Rapids, Michigan this year. And you're welcome to take a look at that for more resources. Palliative Care Fast Facts Neurology has a lot more about other neurologic diseases as well. And there is a neuropalliative care textbook for anyone who's interested. CCALS is the organization that Dr. Makovsky works through, and they also have an educational library on their website. And I'm more than happy to talk with anyone who might be interested in doing a palliative care fellowship after neurology residency, and my contact information is here. And even if you're only a little bit interested, I'm happy to tell you about my experience or start the conversation. So thanks so much for all of your time and for listening. I'm happy to take any questions. Ben, maybe you can let us know how we're doing on time and
Done.
yeah.
Yeah, sure. We are kind of right on time, but if there is a question or a couple questions, we are happy to just wait for a couple minutes. It's more to make sure we respect your time. We are all good to go.
Got it. Okay.
And this is Susanna again.
Yeah.
Please feel free to reach out to me. My email is Susanna, SUZANA, @ccals.org. I'm happy to answer any questions, be a resource as well. Even do joint visits with any of your ALS patients if you end up seeing them. And can I just highlight a couple things that you brought up? One is just in terms of anticholinergics, you mentioned glycopyrrolate, and I think this is just helpful to know. Glycopyrrolate compared to some of the others is a quaternary amine, so it doesn't cross the blood-brain barrier. So it doesn't cause the delirium and that kind of side effect that some of the other anticholinergics do. So it's just helpful. And then the other thing, if someone's having a lot of posterior secretions, sometimes I worry, sometimes I ask to work with the dietitians if they're getting tube feeds, are the timing of the tube feeds, because sometimes it's microaspiration that is leading to the posterior secretions, and just working and different shifts in the types of tube feed that's provided, and whether it's a continuous slow feed versus boluses, and if someone's sitting more upright during the feeds and for half an hour afterwards, those are things that sometimes can help those posterior secretions as well.
Okay.
And then lastly, if the patient does have dementia, there's a really nice website that was developed by somebody here in New York State called dementiadirectives.org. And there they talk about the stages of dementia that are more akin to Alzheimer's type dementia, but it's a very nice framework to think through how aggressive someone might want to be at the different stages of dementia. And so if someone does have early symptoms of cognitive decline with ALS, pulling out that website might be something you could send home with the patient and family to think through, because they might have different ideas of what they want to do. So I just wanted to share those few other pearls, and please feel free to reach out to me. I am available. I love to teach. I love to be a support. I went to U of R undergrad, so I have a particular love for this community, and I am available.
Yeah.
I was gonna say, I do not see any questions in the chat. Dr. Sehgal, Dr. Makovsky, thank you so much for coming here and sharing with us today. For those of you who are here, this will be on our YouTube channel, and we will send it out through our marketing. Thank you so much, and have a wonderful day.